Understanding why pancreatic cancer location and association with major blood vessels affect treatment plan. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has received a diagnosis of pancreatic cancer involving blood vessels, you're in the right place. I know hearing words like unresectable or borderline resectable can feel overwhelming and frightening, but today we're going to talk about how advanced surgical techniques have fundamentally changed what we can achieve. This cartoon image at the top shows the simple anatomy of pancreas to the stomach, bile duct, liver, and small bowel. The image below that shows the anatomy of the all-important veins. The bring blood back from the bowel, superior mesenteric vein known as SMV, which joins with splenic vein to form the portal vein. These veins transport blood to the liver. In this final cartoon, we can see the important arteries added in, called the superior mesenteric artery, SMA for short. You can see this in the bottom of the picture. This main artery supplies blood to small bowel and 70% of large bowel. The other main artery is the celiac artery, which has a branch called the hepatic artery, which supplies blood to the liver. Armed with this basic understanding, we can now understand why the tumor location impacts the complexity of the operation. Venous reconstruction during pancreatic surgery means removing and rebuilding major blood vessels, specifically the portal vein or superior mesenteric vein, abbreviated as PV or SMV, when they're involved with pancreatic cancer. Tumors of the pancreatic head sit extremely close to these critical veins that drain blood from the intestines to the liver. Not long ago, if a tumor touched these vessels significantly, surgery simply wasn't offered. Encasement of the SMV, or portal vein, meaning tumor involvement of more than 1/2 of the vessel circumference, used to be an absolute criterion for unresectability. That meant no surgery, period. However, with increasing experience in vascular reconstruction, fewer pancreatic surgeons view such cases as unresectable anymore. Many specialized centers have now demonstrated the feasibility of SMV reconstruction, and current medical consensus considers pancreatic resection with PV or SMV resection and reconstruction a standard approach. You need adequate inflow and outflow veins present, meaning suitable vessel segments above and below the tumor that allow for safe and complete resection and vein reconstruction. The tumor also cannot involve the superior mesenteric artery or hepatic artery, and surgeons must be able to accomplish what's called an R0 or R1 resection. That's removal with clear or microscopically involved margins. According to the National Comprehensive Cancer Network guidelines, borderline resectable pancreatic cancer now includes tumors with solid contact with the SMV, or portal vein, greater than 180 degrees. That's more than half the circumference with contour irregularity, or even thrombosis of the vein, provided there is suitable vessel on either side. This represents a fundamental expansion of who can benefit from surgery. This concept is shown in the image. The surgeon determines from scans what length and circumference of the vein is involved. The depth of venous vessel invasion is categorized as superficial deep or true tumor at the intima, the inner lining, or in contact with the vessel lumen itself. Research has found that deeper invasion, meaning tumor reaching the intima or lumen, represents an independent prognostic marker for poorer survival, compared to superficial invasion, affecting just the wall or outer layer called the adventitia. Most surgeons cannot reliably determine tumor adherence or invasion of portal vein, or SMV, before surgery, so final decisions about vascular resection often happen during the operation itself, after the pancreatic neck has been divided, and the surgeon can directly assess the vessels. The decision about whether vascular resection will benefit survival depends heavily on this depth assessment. This image determines some of variable locations of tumors and how these may impact intraoperative decision-making. It is essential that all complex pancreatic cancer presentations are assessed by experienced multidisciplinary teams, including surgeons, radiologists, oncologists, and other specialists. They work together to determine which patients may benefit from chemotherapy before surgery, called neoadjuvant therapy. The modern agents have the potential to improve the rate of tumor removal and better outcomes of complete removal and longer survival. This is covered in more detail and other videos in this series. When compared with standard pancreatic duodenectomy, that's the Whipple procedure, without vein resection, adding SMV-PV resection increases the resection rate, but it has been associated with a greater risk of complications and a higher mortality rate, even at very high-volume centers. It's essential to have realistic expectations. Portal vein thrombosis, that's blood clot formation in the reconstructed vein, developed in 16% of patients who underwent pancreatectomy with PV resection, occurring at a median of 15 days after surgery. When SMV or PV thrombosis occurs, it's associated with increased 90-day mortality, jumping from 4.9% to 16.7%, and an overall 30-day complication rate, increasing from 42.9% to 69.4%. This includes a nearly 5 times increased risk of postoperative sepsis. The type of reconstruction matters significantly. Synthetic interposition grafts, that's using artificial material to bridge the gap, carry the highest risk for thrombosis compared to using your own vein or performing direct reconnection. These findings make careful patient selection absolutely mandatory when major venous invasion is suspected prior to surgery. Furthermore, SMV-PV resection should only be performed at high-volume centers institutions that do many of these operations and generally after neoadjuvant treatment. That's chemotherapy given before surgery, especially in cases of borderline resectable disease to shrink the tumor and improve the chances of complete removal. The survival benefit of SMV-PV resection is variably reported, most likely due to heterogeneity in the completeness of resection. What that means in plain language outcomes depend heavily on whether surgeons achieve clear margins complete tumor removal. Multiple systematic reviews and meta-analyses have examined this question. One 2016 meta-analysis found benefits of portal superior mesenteric vein resection in pancreatic resection for ductal adenocarcinoma. This image demonstrates how the veins are rejoined after tumor removal. The superior mesenteric artery margin is the most important driver of survival because it's the most frequently involved positive margin in up to 85% of cases where margins are positive. There's no protective fat or tissue between the uncinate process of the pancreas and this artery. This is why adequate patient selection is so crucial. If you're supporting someone through this decision, understand that successful venous reconstruction doesn't guarantee cure, but it offers the only chance of cure for selected patients who would otherwise have no surgical option at all. The key is matching the right patient to this complex intervention. While venous reconstruction has become accepted, practice arterial resection and reconstruction tells a completely different story. Current medical consensus does not advocate for arterial resection and reconstruction in pancreatic cancer. The superior mesenteric artery courses behind the pancreas and sits posteromedial to the SMV, which makes involvement of this artery unlikely without simultaneous SMV involvement. When it does occur, it typically represents more advanced disease. Multiple systematic reviews have associated arterial resection in patients undergoing pancreatectomy with poor short and long-term outcomes. There's currently no evidence to support arterial resection outside of clinical trial settings. The one exception is tumors of the body of the pancreas involving the celiac axis or common hepatic artery, which can sometimes be resected without reconstruction through a procedure called the modified Appleby procedure, but this is highly specialized. If you've been told your pancreatic cancer is unresectable based on vein involvement, ask specifically, is this because of venous involvement only, or is there arterial involvement? Request, would my case be considered borderline resectable by current NCCN guidelines? Inquire is referral to a high-volume center with vascular reconstruction experience appropriate for my situation. Question, would neoadjuvant chemotherapy potentially make my tumor resectable? If venous reconstruction surgery is being recommended, ask what is this center's experience, specifically with portal vein or SMV reconstruction. Request specific data. What are your rates of portal vein thrombosis and 90-day mortality for these procedures? Discuss what type of reconstruction technique would be used, in my case, primary repair vein graft or synthetic graft. Understand the timeline. What neoadjuvant treatment is recommended before surgery, and how long will the entire treatment course take? You should strongly consider referral to a specialized high-volume pancreatic surgery center if your local surgeon suggests your tumor is unresectable due to vein involvement. You've been diagnosed with borderline resectable disease. Portal vein or SMV involvement greater than 180 degrees has been identified on imaging. Your imaging shows vein irregularity or thrombosis, but suitable vessel segments exist above and below. The data is clear these complex vascular reconstructions should only be performed at high-volume centers. Gather your imaging and medical records. Request copies of all CT scans, specifically multiphasic contrast-enhanced studies. Get the radiology reports that describe vessel involvement in degrees of circumference. Compile pathology reports if biopsy has been performed. Understand your disease classification. Review whether your cancer is classified as potentially resectable, borderline resectable, or locally advanced unresectable. Understand that these definitions have evolved significantly and vary by institution. Prepare for neoadjuvant treatment, meaning chemotherapy before surgery, if surgery is planned. If you have obstructive jaundice, biliary stent placement will be necessary before chemotherapy can start. Understand that neoadjuvant therapy chemotherapy before surgery is generally recommended for borderline resectable disease. Expect treatment to potentially last several months before surgical reevaluation. Build your support system. If you're supporting someone through this, recognize that hearing borderline resectable after initially being told unresectable can feel like whiplash emotionally. Connect with pancreatic cancer support organizations that can provide both information and emotional support. Consider second opinions from pancreatic cancer centers of excellence. If you undergo venous reconstruction, understand realistic timeframes. Portal vein thrombosis risk is highest in the first 15 days after surgery. Close monitoring with imaging will be necessary in the early postoperative period. Overall complication rates are higher than standard pancreatic surgery. Some patients may require anticoagulation blood-thinning medication to prevent clot formation. Advanced venous reconstruction techniques have fundamentally expanded surgical options for pancreatic cancer patients previously considered inoperable. Your next step: seek evaluation at a high-volume center if you have vessel involvement that might be reconstructable. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. National Comprehensive Cancer Network, NCCN Guidelines for Pancreatic Adenocarcinoma, provides the formal definitions of resectability categories. American Society of Clinical Oncology ASCO Guidelines for Locally Advanced Pancreatic Cancer Management. The Pancreatic Cancer Action Network, Patient Support and Information Resources. High-Volume Pancreatic Surgery Centers lists, from the Alliance of Dedicated Cancer Centers. All links are available in the description below. Thank you for watching.